Well, hello everybody, and my name is Heather Brown, and welcome to this Fuse Health Inequalities themed seminar. And thank you, Ted, for agreeing to present. I hope this will be a thought-provoking seminar. Just want to give a brief summary about Ted. So Ted is a political scientist working at Newcastle University in the Population Health Science Institute, and he has an interest in the political economy of health. Especially health inequalities as they're affected by neoliberal globalization. And I guess just a few bits of housekeeping. So if you have any burning questions during the seminar, then feel free to post them in the comments box, which should be on the bottom of your screen. And as well, if everyone during the seminar can keep muted and their camera off, it will just make it go the bandwidth a bit easier. And I think that's it. So I hope everyone enjoys the seminar. Thanks. I guess over to you, Ted.
Right. So my PowerPoint's showing?
Yeah, Ted, I can see that there, thanks.
Brilliant. Okay, well, thanks to all for joining. And I think a few more people will be filtering in. I don't apologize for the rather blunt title, because it seemed to me the best way of getting people's attention at a time when we are thoroughly overloaded with COVID-19 news and misinformation. So the outline of the presentation is quite simple. I will first say a bit about the concept of structural violence and its applicability, then talk about the background in terms of post-2010 austerity, and finally provide some rather depressing conjectures about the longer-term social and economic consequences of the pandemic. This is, I should emphasize, a probable future. It is not an inevitable one. So the concept of structural violence is most closely associated with the work of physician anthropologist Paul Farmer, who of course was one of the founders of an NGO called Partners in Health, which has done a lot of work in Russia and Haiti. And there are various definitions kicking around. My own preferred one is this one. Structural violence is the end point of a set of social and economic processes and choices that operate at arm's length to generate forms of illness, suffering, and death that would be understood as violent if they resulted from in-person interactions. And here in the UK, of course, we have a particularly horrific example of such processes in the Grenfell Tower fire, which happened just over 3 years ago. And at the time, there was some commentary that didn't quite use the terminology of structural violence, but came pretty close. So I think it's not inappropriate to use that concept as a frame for the vastly larger scale consequences of the pandemic. So, on to the background. As you know, since 2010, we have had a decade of austerity in public policy, combined with factors like the rise of precarious employment, the number of workers on 0 hours contracts quintupled over the course of the decade. And the end product has been a redistribution of income and wealth, and indeed of opportunity, upward. And that could be the topic of an entire presentation, so I'll just give you 2 illustrations. This is the Institute for fiscal studies analysis of the impact of tax and benefit reforms post-2015, with the change in annual net income on the left-hand axis, the change in percentage of net income on the right-hand axis, and the income decile groups across the bottom. And you can see that the effect here has been to take money out of households at the lower end of the income distribution and redistribute it upwards to people at the top of the distribution. This is really an understatement because it doesn't reflect such factors as the preferential tax treatment of capital gains, which hasn't changed but involves a form of income that's overwhelmingly concentrated at the top. There was and is a spatial dimension to this process as well. These are data assembled by Christina Beattie and Steve Fothergill at Sheffield Hallam, showing the percentage of small areas in the most deprived 20% for all the local authorities. And on the vertical axis, the loss in 2020, 2021, which is to say right about now, from benefit reforms per working age adult. And you can see that the effect over the decade has been to take up to £1,000 per working age adult per year out of some of the poorest areas in the UK, right? So you might think of this as unleveling up. We know as well that at the start of the decade, on the basis of the analysis from the Great British Class Survey, a third of the population had an average of just £1,000 in household savings, which doesn't take you very far if you have an emergency or you lose your job, and explains why people in increasing numbers are gravitating to outlets like this one in Stockton-on-Tees, where I used to live, that is lending at 242.1% annual percentage rate. Right. All that's been compounded by an average 49% cut in central government grants to local authorities, with, again, the cuts concentrated in cities and in relatively deprived areas of the country. And here's what the mayor of Liverpool, one of the hardest hit areas in the country, had to say a few years ago about the impact of the cuts. And I should point out that, like a few other things I'm going to be citing, this is not out of Jeremy Corbyn's playbook. This is out of The Economist. So not a source that is intrinsically unsympathetic to austerity. No. All that is just to say the unequal impacts of the pandemic must be understood against this background. And the point here is not that these impacts are unique. They're not. And I'll be giving at least one example of that. But rather that austerity in the UK and elsewhere where it's been applied has magnified some of those impacts, and in particular imperiled prospects for recovery and for reducing the health inequalities that the pandemic is certain to magnify. So we know, for example, that COVID-19 deaths are more than twice as frequent in the most deprived fifth of, or almost as twice as frequent, sorry, in the most deprived areas as in the least deprived, which are over there on the left-hand side of the screen. Just as an aside, these are age-standardized mortality rates, which are not really the most appropriate measure. I haven't received a reply to my query about the raw data, but since we don't know anything about the distribution of the age distributions by deprivation decile, this may be overstating the impact of deprivation. It may be understating it. We don't know. So in my teaching this fall, I'm going to be using this as an illustration of a case where age standardization is not appropriate. Now, I mentioned comparisons. Here is an illustration from Montreal, which is the city I think of as my Canadian home. And you can see that there's just a remarkable degree to which the total number of confirmed COVID-19 cases maps onto total income of households inversely. In other words, the poorer the area, the higher the prevalence of COVID. And if you know the city at all, that much of this will not surprise you. What we have as well is the near collapse of public health, so that by 2015, Nigel Edwards and colleagues were pointing out that the sum of all NICE commissioning guidance for an area would almost certainly be unaffordable. And my colleague, Alison Pollock, has pointed out that the cuts to community-based communicable disease control, along with the legislative reorganizations, created what she calls a perfect storm, where people with the necessary experience in basic public health were actually made redundant. So on to the ways in which inequality has already been magnified, and I'm indebted to McKinsey and Company for their gracious permission to share these next graphs with you. This is simply a chart showing you the extent of work loss. We have about 25%, about a quarter of the population furloughed, off sick, or in isolation, or newly unemployed. That in itself, that's a staggering number. There's few, if any, precedents for that occurring over a very short period of time. But the impacts are not equally shared. They are disproportionately concentrated in accommodation and food services. And of course, quite a few of those jobs are likely never to return. Retail trade, large number of jobs at risk, with about 1/5 of the workforce on furlough, and so on and so forth, right? The critical point here is that professional, scientific, and technical people, who tend to be the ones getting quoted in the media about the risks, are not necessarily the people bearing them, at least not in economic terms. Half of the jobs classified as at risk pay less than £10 an hour, okay? You can see that the high-risk jobs are disproportionately concentrated at the low end of the hourly pay scale, right? Higher up in the wage distribution, very few jobs at risk. The most affected sectors tend to have a significantly lower share of employees with tertiary education. Not entirely surprising. Those are the jobs in accommodation and food services, retail, construction, and so on. Interestingly enough, the manufacturing sector does not appear to be as heavily at risk in these slides as some of the media coverage would have us believe. And here again, there is a regional dimension, right? The black areas on the left-hand map are the poorer regions. The black areas on the right-hand map are the regions with the largest percentage of jobs at risk. And you can see that, again, there's a very close mapping there that suggests that, far from leveling up, the impacts are in fact going to worsen existing inequalities. Needless to say, the ability to work from home, as I suspect almost everyone on this call is doing, is unequally distributed, right, across income groups, across employment sectors, and by region, right? So the darkest municipalities, the darkest dots on this map are the places where the highest proportion of people can work from home. And you see, and not entirely surprising, London, Oxford, Cambridge, Manchester, and Leeds, maybe a bit of a surprise. Among the lowest percentages, Middlesbrough and Sunderland, just down the road from where I am. And again, the ability to compensate for the effect of prolonged school closures is not equally distributed. And we're hearing more and more authoritative voices pointing out that this is likely to have some of the most severe longer-term intergenerational effects. Everything we know, I can't emphasize this too much, everything we know about health inequalities and social determinants of health tells us that economic shutdowns are a public health menace. So it's not about protecting health versus protecting the economy. The intelligent approach is protecting health by protecting the economy in the most equitable way possible. Now, temporary measures have eased the threat, here as elsewhere. But, for example, the £3 billion that have been announced as support for local governments in the crisis are about a fifth of the amount that, according to the Local Government Association, local governments have lost over the course of the austerity decade. And we're not out of the woods yet. Recent letter in the Lancet points out that the initial economic measures were in place for 3 months. They've now been extended to 7 months, but we are looking at 12 to 18 months of public health measures. And then there is the, to my way of thinking, unforgivable endangerment of people on the front lines through shortages of personal protective equipment. This is not Jeremy Corbyn talking, this is the National Audit Office, an excellent piece that they just recently released. One of the most disturbing things here is the minimal amount of personal protective equipment that was provided to social care. And this leads to one of the aspects of the pandemic that I think most clearly demonstrates the appropriateness of the structural violence rubric, the care home cull of the elderly. And here, as you can see, the UK is by no means the worst offender, as bad as things have been here. In Canada, I am sorry to say, on the most recent official figures, 4/5 of all COVID-19 deaths occurred in care homes. And in the country's 2 largest provinces, some of the care homes have literally turned into charnel houses, and the army has had to be called in to sort the casualties. Meanwhile, as you can see, treatment for other conditions is suffering over the short term. And over the long term, Nigel Edwards and colleagues have pointed out that, in fact, we will have a middle-income country's public healthcare system, not a high-income country's, which probably means that there will be a drift over time to a 2-tier system like Brazil's or Chile's. And the connecting thread here, I would argue, with Monbiot, whom I don't always agree with by any means, is that the austerity mindset has been linked to depreparations based on refusal to front load the costs. Okay. That said, I think it's also the case that assessing the success of any European jurisdiction's response won't be possible for years, if not longer, because we can't capture over the short term things like the impact of deferred treatments, the effects of economic insecurity, the effects of foregone schooling, the deaths of despair that Anne Case and Angus Deaton write about, and so on and so forth, right? As I've said in one of my blog posts, dead is dead. So what we really need to look at is the total number of excess deaths and their distribution. And of course, we don't know that yet because the people who aren't getting cancer treatment haven't died yet. So on to the third part of the talk, which is that despite much of the coverage, in some respects, the current situation is not unprecedented, right? In terms of its worldwide scale, it is. But in terms of what you might call national depth, we have a fairly clear model in what happened after the collapse of the Soviet Union, which is why my title is what it is. The economy contracted by close to 50%, social provision and much of the healthcare system crumbled, average wages plunged, and poverty increased drastically. And as a consequence, the population lost nearly 5 years of life expectancy over 3 years. That's basically the only parallel in recent history is the effects of HIV/AIDS in some countries in sub-Saharan Africa. This shows you what happened to life expectancy in the Russian Federation. This is when the implosion starts, right at the end of the 1980s, and you can see the decline there. There is a recovery after about 1994, 1995, takes us up to 1998 when a financial crisis forces the devaluation of the ruble, people's earnings decline again, the real value of people's earnings declines, and you can see life expectancy basically drops back to 65. And then it begins to recover. But all is not well. The crisis was worsened by shock therapy economic policy, right? Again, so even in Russia, this was not inevitable. And despite economic recovery, this is critical. A quarter century later, life expectancy is still 6.5 years lower than you would predict based on Russia's gross domestic product per capita. You see that on the Preston curve here. I hope people are familiar with the Preston curve. You can't see the trend line, but you can see that Russian life expectancy is substantially lower than slightly richer Poland or slightly poorer Chile, right? So that's the effect a quarter century on of the economic collapse. Why? There's lots of reasons. Some people focus on alcohol consumption, but I would argue with Case and Deaton that that's something that demands an explanation rather than providing one. One thing we do know is that recovery was associated with drastic increases in inequality. This shows you the income share before taxes of the top 10% of the population in Russia, the USA, and France, and you can see that within a matter of a couple of years, you get an increase in inequality basically to the levels of Tsarist times. The drastic increase in inequality, creation of a new class of oligarchs who are quite familiar, and capital flight to the extent that half of all Russians' financial assets are estimated to be held outside the country. So the bottom line, as they say here, is for me that the legacies of a decade of austerity, compounded by short-term planning and implementation failures, and we shouldn't minimize those, may stretch across a generation, as they did in Russia, to create a UK that is probably poorer, certainly meaner, certainly less healthy, and far more unequal than it could be. Now, I say it could be because the outcome is not inevitable, but what we need now is serious discussion about the what do we do now questions. And so far, I don't see that happening at anything like the requisite level of detail, despite what's going on internationally. And internationally, you get this remarkable document coming out of the Organization for Economic Cooperation and Development that emphasizes reductions in inequality and investment in the green economy, right? I mean, this is a Green New Deal on a scale that the House Democrats in the United States would never have dared to suggest. And you get the World Economic Forum talking about a new social contract centered on human dignity and social justice, right? There's a bit of ambiguity about how this is all going to be paid for, right? There's a bit of ambiguity in Monbiot's work as well on that point. But my point here is simply that we are not seeing the necessary engagement with these what do we do now questions. What we're seeing, to my way of thinking, is a policy landscape that looks quite a lot like this. A lot of heads in the sand. Well, thank you for listening. I've rushed through a fair amount of material quite quickly, but we have lots of time for questions.
Thank you, Ted, for an interesting talk. Now we're just going to have a brief 5-minute response from Charlotte Clare. Charlotte, if you'd like to turn on your video, and Ted, if you could please stop sharing your screen for the moment, and we can bring it back if that's okay.
Done.
Hello. Ted, that was wonderful. Thank you very much indeed. Quite a kind of, in really very few minutes, you've taken us through quite a scope of things there. I should introduce myself. I'm Charlotte Clarke. I work as the Executive Dean for the Faculty of Social Sciences and Health at Durham University. I've worked in the Northeast for quite some time, on and off. So I just want, if I may, to highlight some things that really stood out for me, but I'm left thinking, if I thought the job of the day was figuring out how to reopen university buildings and teach online, then I need to change my perspective a bit. That is not the job of the day. We have our work cut out here. So you've spoken so eloquently, so convincingly, about the need for us to understand the amplifying effect of the pandemic on the most deprived communities. And we've seen that coming through. So we absolutely need to keep that in mind, know that as we go forward. You've also spoken very powerfully about the ability or lack of ability, perhaps lack of capacity of some communities to have that compensatory effect of retreating to our own homes, the impact on schooling and things like that. So if we can focus our attention on how to mitigate those weakened compensatory capacities, then we may be heading somewhere in the right direction. Really important message about protecting health by protecting the economy. So we've got to go beyond the short-term thinking of keeping away from the economy and protecting health that way. We've got to move rapidly through what feels like a very precarious and quite risky point of opening up again. But if protecting the economy is the way of protecting health as it is, then we absolutely need to do that. My own work is predominantly around people in later life and people with dementia. So your message around the impact on people in care homes absolutely hits home. I've been quite devastated to see the impact on people with dementia, disproportionately impacted, the impact on people in care homes, absolutely just kind of left out there in our societies and not the protection there that we might in our society have wished. You point our eyes to thinking about, well, how will we actually know what the impact of this is? How will we know, and we won't know for some time, what the kind of life expectancy is, or the damage to life expectancy, but we ought to be prepared for seeing a decline in that. And then what do we do about this? So the OECD talking about more than ever, as if we didn't before, we absolutely have to focus on reducing inequalities. We have to, that's where we have to go. And in that, the green economy. So this is about moving beyond thinking about individual health status into thinking about the welfare and well-being of communities and societies. But it also steps us into that space of thinking about how we as a people, we as our communities and societies interact with the environment that we're living in. So it brings the green agenda right centre stage into public health as well. So really, I very much welcome the opportunity to have heard what you've been talking about here, Ted, to be inspired by it. And I urge all of us to take up this mantle, to thinking beyond today and tomorrow, because the impact on life expectancy is going to be felt for a decade or more perhaps is the more realistic answer. And so for all of us who contribute in any way to public health, we've got to absolutely look to see how we can impact on those inequalities, wealth inequalities, and therefore health inequalities. So thank you very much indeed, Ted.
Well, thank you.